I'm just going to quickly run over the common headaches that come out in AKT. So I've just made a tiny table to just put the headache type and their treatments and prevention where available. So the first one is migraine headaches. So we know about it. Someone has talked about it a while ago. It's usually a kind of headache where the patient complains that it's on one side, and they would describe it as a throbbing headache or someone banging their head. But in children, it could be bilateral, and it may also present as abdominal pain in children. So it's important for us to know that. So by way of treatment, it's usually advised to try the non-steroidal anti-inflammatory medications, and aspirin is also given. So ibuprofen can be taken up to 600 milligrams instead of the traditional 400 milligrams if there is no response. Aspirin dose for migraine is usually 900 milligrams. If that is not helpful, paracetamol 1 gram can also be tried, and triptans are also used for acute attacks if there is poor response to the other ones I've mentioned. For prophylaxis, propranolol is used, but we're careful not to use this in asthmatics. And the second line is topiramate. The thing to note there is that it's teratogenic, so it's not advisable in women of childbearing age. And if they have to take it for any reason, would have to make sure that they're taking very good contraception. So if you have a patient who cannot take propranolol and cannot take topiramate, maybe a woman of childbearing age who is asthmatic, you can also give amitriptyline 10 to 20 milligrams at night as prophylaxis. Another thing about the AKT that I read about was that in women who have menstrual migraine, the agent to give them would be fovitriptan or zomitriptan. That would help for them to control that symptom, not just the sumatriptan or the other ones. And that is actually defined as migraine occurring 2 days before the period and 3 days after the period for at least 2 or 3 consecutive menstrual cycles. So that's what you would define as menstrual migraine. So in that situation, zomitriptan and fovitriptan are usually given. Then the second one is the tension type headaches, where the patients would usually describe it as something like a tight band going around their head. In the history, you might get a history of someone who is like a high achiever, a very active person, maybe a doctor, a banker, something that kind of, I would say, maybe like stresses or tenses them. So if the person is having this symptom, this headache, so NSAIDs, aspirin and paracetamol can also be used. For the prevention, NICE advises that 6 to 10 sessions of acupuncture, physiotherapy, CBT, and exercises do usually make an impact. But if they are not working, amitriptyline again can be tried, and is found to be helpful in a number of patients. The third one I will talk about is the cluster headache, which is the really bad one, where the patient is woken up by this very bad unilateral headache that makes them feel very agitated. They can be pacing about in the room. It's usually unilateral, but it's important to know that sometimes it switches sides. So the person can have a cluster today on the right, and then the next time they're having it will be on the left. But the thing to know that is that it comes like in clusters, like one comes and stays and then another one, and then they usually have that at least 5 attacks lasting about 15 minutes to 3 hours. So for the cluster headaches, the treatment is usually a subcutaneous or inhalational triptans, because many times they're having nausea or vomiting, and because of how intense it is, they might not be able to want to take tablets. So The subcutaneous or inhalational triptans are helpful. And if you have access to high flow oxygen, maybe if the patient is sent to the A&E, they will give them 100% oxygen at 12 to 15 liters, and that usually helps. When I also read it in the guideline, they said in some cases they might qualify for home oxygen. I was surprised to see that. So they qualify for home oxygen in this kind of headaches. And for prevention, the verapamil, which is a calcium channel blocker, is also helpful. So you also need to know that verapamil can also lower the blood pressure. So you need to also take a good history to make sure you're not giving a drug that would affect another medical condition they have. And in this case, it's also important to advise the patient about lifestyle things. Then the fourth one is the subarachnoid hemorrhage. The patients would usually describe a headache that they can often tell you when the headache happened. They will describe a headache at the back of their head at the occipital region. Some would describe it as a thunderclap or worst headache of their lives. And when the patient comes, they might even present as if they're having migraine. They don't want to look at the light, but they're having this very bad headache. So you have to take a history and make that diagnosis either with CT scan, which has to be done urgently to rule out or rule in a subarachnoid hemorrhage and a lumbar puncture according to the guidelines. We'll be able to go through all that. So if a subarachnoid hemorrhage is confirmed, it can be treated based on how big the bleed is. It can be treated surgically, and in some cases, oral nimodipine, which is also a calcium channel blocker, can be used. So there is really no set out prevention for it. So you have to manage the risk factors, barium aneurysm or whatever it is that may have caused it. Then the other one is the hemicrania continua, or what some people call paroxysmal hemicrania. It's almost always like the picture usually sounds like a cluster headache. Patient is complaining of a unilateral continuous headache for more than 3 months, like sometimes episodic, but the response to indomethacin would usually give it away. So that indomethacin is kind of used as a treatment and also as a diagnosis. So if the patient is having this kind of headache and they respond to indomethacin, you can invariably make this diagnosis. And in some cases, amitriptyline has been found to be helpful in the prophylaxis. The other one is the medication overuse headaches. So this one is where a patient who has a primary headache, maybe they have migraine normally, and then they continue to take medications for the migraine. Over time, the body gets so used to it that it's like a rebound effect. So they have to keep taking that medication, and if they don't take it, it just keeps happening. So the medication, the headache is not occurring because there is primarily a problem, but I think from the effect of the overuse of the medication, the treatment is basically to stop the many medications they are taking. So you tell them to stop it abruptly, not like they're not tailing down. And also you keep a headache diary. So if you do this, most of them will start having worsening effects of that headache in the first week because they've depended on it for too long. So you need to let them know that, then you bring them back in 2-3 weeks, follow them up to make sure that they're responding and there is nothing else going on. The other one is trigeminal neuralgia. That one, that's where the patient describes an electric shock-like pain around the distribution of the trigeminal nerve, around the cheek and lower jaw. So they will tell you that it's sharp shooting, usually unilateral as well. Treatment is carbamazepine, and closely related to that is the GCA, where the patient also talks about headache on one side, especially around the temples, and we know that diagnosis will be checking the inflammatory markers, ESR, and treatment is high dose prednisolone. So if the patient is already having a visual problem with their presentation, you have to send them to hospital immediately, and they could consider IV corticosteroids or up to 60 to 100 milligrams corticosteroid. But if there is no visual involvement, you can usually give 40 to 60 milligrams. And then, of course, you discuss them with the ophthalmologist to make sure that they are seen, to make sure they don't have this. And prevention, there is really no prevention per se. They will have to be followed up with a lot of serial investigations, and then gradually tailing down corticosteroids over time. The other one is the temporomandibular disorders. The patient also describes a pain around the jaw area. It has a lot of other symptoms, but the main thing, the headache part of it there, is that you would have made sure that you've ruled out other causes of headache, and you've kind of then found out that the headache is attributable to that temporomandibular disorder. And when you palpate the temporalis muscle, the headache will be reproduced in the patient. So treatments will be simple analgesia. You can give diazepam and amitriptyline, some of those neuropathic painkillers. Prevention will be lifestyle, where you tell them about yawning, avoiding activities that would worsen it, like yawning, opening their mouth widely. I also advise them to eat soft food, so they don't chew a lot. The other one where we can have headache that can come out in AKT is carbon monoxide poisoning. So the patients would usually describe a headache. It will not just be only the person. It will be like people in that household. It could be maybe people in a hostel or something. So they have a lot of headache when they're at home, but when they go out, the headache seems to resolve. So it's not, you have to get that history, and then you have to ask about the kind of energy they use, if they're using open stove or anything that is I'm trying to remember the word, like whatever exposes them to carbon monoxide. So it depends on how long they've been exposed to it, or the dose of what they've inhaled. That would indicate what they will present with. So if it's a high level of carbon monoxide, headache might not even be what you're seeing. They might even present in coma and have other problems. But in smaller doses, headache is usually the commonest presentation, and the treatment is basically 100% oxygen, and you have to give them that using a tight fitting mask. And if the patient in the history, you have to take note whether the patient is a smoker or a non-smoker, because when you give them the 100% oxygen, you have to continue that until the patient is asymptomatic, and then the carboxyhemoglobin is less than 2% in non-smokers or less than 10% in smokers. So basically, you're giving the oxygen over 6 hours. You check their level of response, and then measure the carboxyhemoglobin levels. If it's less than 2 in a non-smoker or less than 10 in a smoker, then that they're responding to treatment. And the last one is the cerebral sinus thrombosis, which is like a form of stroke, leading to thrombosis of some of those cerebral sinuses, and then one of the presentation would be a headache, and in this case they will also have some neurological symptoms. So the treatment would be, you do the history, and then you investigate, do your imaging and find where the thrombus is and take it out. And then prevention would be to manage whatever the risk factors were that may have predisposed to the thrombosis. So that would be it for the headaches.